When chest pain from ischemia is prolonged and not immediately reversible, acute coronary syndrome may develop. Acute coronary syndrome, which is your unstable angina and your non-ST segment elevation myocardial infarction, or NSTEMI, non-STEMI, and ST segment ME. Patients with unstable angina, or an NSTEMI, may or may not have ST segment depression and or T-wave inversion on the EKG. For patients with chest pain who do not have an ST segment elevation or an ST T-wave change in the EKG, it is difficult to distinguish between unstable angina and non-STEMI until we evaluate serum cardiac biomarkers. The figure shown in this slide shows the relationship among coronary artery disease, chronic stable angina, and acute coronary syndrome. When patients first present with chest pain, ST elevations on the 12-lead EKG most likely indicate a STEMI. As previously mentioned, the EKG should be compared to a previous EKG whenever possible. ST elevation represents myocardial injury that is potentially reversible, but if not treated, will likely evolve into permanent necrosis or tissue death of the myocardium. On the cellular level, the heart muscle becomes hypoxic within the first 10 seconds of total coronary occlusion. Heart cells are deprived of oxygen and glucose needed for aerobic metabolism and contractility. Aneurysm begins and lactic acid accumulates. In ischemic conditions, the heart cells are viable for about 20 minutes. Irreversible heart damage starts after 20 minutes if there's no collateral circulation. With restoration of blood flow, which we call reperfusion, aerobic metabolism resumes, contractile plaque ruptures, releasing the lipid core into the vessel. This causes platelet aggregation and thrombus formation. The vessel may be partially blocked by a thrombus, manifesting in unstable angina or a non-STEMI, or totally blocked by the thrombus, manifesting in a STEMI. We are not sure what causes the plaque to suddenly become unstable. Systemic inflammation may play a role. Patients with suspected acute coronary syndrome need immediate hospitalization. So we've been using these terms, and I want to take a few minutes to do some actual definitions for you. Unstable angina is chest pain that is new in onset, or occurs at rest, or occurs with increasing frequency, duration, or less effort than the patient's chronic stable angina pattern. The pain usually lasts 10 minutes or more. The patient with chronic stable angina may develop unstable angina, or unstable angina may be the first clinical sign of coronary artery disease. Unlike chronic stable angina, unstable angina is unpredictable and must be treated immediately. Of the angina, it occurs with increased frequency or is easily provoked by minimal exertion, or occurs during sleep or even at rest. The patient without previously diagnosed angina describes chest pain that has progressed rapidly in the past few hours, days, or weeks, often ending in pain at rest. Changes are referred to as ischemic changes. A myocardial infarction, or an MI, occurs because of an abrupt stoppage of blood flow through a coronary artery with a thrombus caused by platelet aggregation. This causes irreversible myocardial cell death or necrosis. In the heart muscle beyond the blockage. Serum cardiac biomarkers are released into the blood. Most MIs occur in the setting of a pre-existing coronary artery disease. A STEMI caused by an occlusive thrombus results in ST elevation in the EKG leads facing the area of the infarct. ST segment elevation is significant if it is 1 millimeter or more above the isoelectric line in at least two contiguous, which means neighboring leads, except in V2 and V3, where the ST elevation must be 2 millimeters or more. Thrombolytic therapy is done in hospitals that do not have a catheterization laboratory for PCI. Non-STEMI caused by non-occlusion thrombus. Non-STEMI patients usually undergo catheterization within 12 to 72 hours. Thrombolytic therapy is not indicated in non-ST segment elevated MI. This picture shows occlusion of the left anterior descending coronary artery resulting in a myocardial infarction. It's an acute myocardial infarction in the posterior lateral wall of the left ventricle. This is shown by the absence of staining in the area of necrosis where the white arrow is. Note the scarring from a previous anterior wall myocardial infarction. That's where the black arrow is. The acute MI process evolves over time from The acute MI process evolves over time from hours to a few days. If ischemia persists, it takes 4 to 6 hours for the entire thickness of the cardiac muscle to necrose. If the thrombus is not completely blocking the artery, the time to complete the necrosis may be as long as 12 hours. The location of the MI and EKG changes correlate with the involved coronary artery. In most people, the right coronary artery supplies blood to the inferior and the posterior left ventricular walls. Blockage of the right coronary artery results in an inferior wall and or posterior wall MI. Anterior wall infarctions result from blockage of the left anterior descending artery. Damage can occur in more than one location. Right ventricular MIs are less common and treated differently than left ventricular MIs. The degree of collateral circulation, everyone develops collateral circulation. A person with a long history of coronary artery disease may develop good collateral circulation to provide the area surrounding the infarction site with an adequate blood supply. This is one reason why a younger person may have a more serious first MI than an older person with the same degree of
Not relieved by rest, position change, or nitrate administration may mean the patient is having an MI. Persistent and unlike any other pain, it is usually described as heavy pressure, tight, burning, constricting, or a crushing feeling. Common locations are the substernal or epigastric area. The pain may radiate to the neck, lower arms, or to the back. The patient may relate it to indigestion, taking antacids without relief. It usually lasts for 20 minutes or longer and is more severe than chronic angina pain. Not everyone who has an MI has classic symptoms. Some patients may not have pain, but may have discomfort, weakness, nausea, indigestion, or shortness of breath. Some women may have atypical discomfort, shortness of breath, or fatigue. Patients with diabetes may have a silent or an asymptomatic MI because of the cardiac neuropathy or atypical symptoms such as shortness of breath. An older patient may have a change in mental status such as confusion, shortness of breath, pulmonary edema, dizziness, or dysrhythmia. During the initial phase of an MI, the ischemic heart cells release catecholamines such as norepinephrine and epinephrine that are normally found in these cells. These result in diaphoreses, increased heart rate and blood pressure, and vasoconstriction of the peripheral blood vessels. On physical examination, the patient's skin may be ashen, clammy, and cool to touch. As previous stations in response to the release of catecholamines may include blood pressure and heart rate that are high initially. Later, the BP may drop because of decreased cardiac output. If severe enough, this may result in decreased renal perfusion and decreased urinary output. Crackles, if present, may persist for several hours to several days, suggesting left PD, hepatic engorgement, and peripheral edema may mean right ventricular dysfunction. Examination may reveal abnormal distant heart sounds. Other abnormal sounds that suggest left ventricular dysfunction are an S3 and an S4. A loud holosystolic murmur may occur with ventricular septal or mitral valve dysfunction, such as mitral regurgitation. The patient may have nausea and vomiting. These symptoms can result from reflex stimulation of the vomiting center by the severe pain. They can also result from vasovagal reflexes initiated in the area of the infarcted heart muscle, especially with inferior wall MIs. The temperature may increase to 100.4 within 24 to 48 hours. The temperature elevation may last as long as 4 or 5 days. This increase in temperature is due to systemic inflammatory processes caused by the death of myocardial cells. The body's response to cellular death is the inflammatory process. Within 24 hours, leukocytes infiltrate the area. The dead heart cells release enzymes that are important diagnostic indicators of MI. We've talked about them already. They're called biomarkers. Once the infarction takes place, catecholamine-mediated lipolysis and glycogenolysis release plasma, glucose, and free fatty acids to be used by the O2-depleted myocardium for anaerobic metabolism. For this reason, serum glucose levels are often high in MI. The necrotic zone of a STEMI is identified by EKG changes within 1 or 2 days. At this point, neutrophils and monocytes that have collagen matrix that will eventually form scar tissue is laid down. At 10 to 14 days after MI, the new scar tissue is still weak. The heart muscle is vulnerable to increased stress during this time. At the same time, the patient's activity level may increase, so special caution and assessment are necessary. By 6 weeks after MI, scar tissue has replaced necrotic tissue and the injured area is considered healed. Often the scarred area is less compliant than the surrounding areas. This condition may be manifested by abnormal wall motion on an echocardiogram or nuclear imaging, left ventricular dysfunction, altered conduction patterns, clear imaging, left ventricular dysfunction, altered conduction patterns, dysrhythmias, or heart failure. The scarred area may become an irritable focus for life-threatening dysrhythmias, causing sudden cardiac death even years later. These changes in the infarcted heart muscle can also cause changes in the unaffected area. Remodeling of the normal myocardium can lead to the development of late heart failure, especially in the person with atherosclerosis of the other coronary arteries or an anterior MI. As previously mentioned, ACE inhibitor drugs are given to limit ventricular remodeling. Dysrhythmias are the most common to 90% of patients. Ventricular tachycardia and ventricular fibrillation are the most common causes of death in patients in the pre-hospital period. After MI, bradycardia, such as a complete heart block, develop when the key areas of the conduction system are destroyed. Ventricular tachycardia or ventricular fibrillation, onset of pain. Premature ventricular contractions or PVCs may precede ventricular tachycardia or ventricular fibrillation. Heart failure is a complication that occurs when the right or left ventricular pumping action is reduced. Depending on the severity and the extent of the injury, left-sided heart failure occurs initially with subtle signs such as mild dyspnea, restlessness, agitation, or slight tachycardia. Signs of right-sided heart failure include jugular vein distension, hepatic congestion, or lower extremity edema. If you don't remember, you might refer back to chapter 34 in your book for information about the treatment of acute decompensated heart failure. Cardiogenic shock occurs when O2 and nutrients supplied to the tissue are inadequate because of severe left ventricular failure, papillary muscle rupture, ventricular septal rupture, left ventricular free wall rupture, or right ventricular infarction with PCI or thrombolytic therapy. Cardiogenic shock associated with a high death rate requires aggressive management. Papillary muscle dysfunction or ruptured papillary muscle dysfunction may occur if the infarcted area includes or is near the papillary muscle that attaches to the mitral valve. Suspect papillary muscle dysfunction if you hear a new systolic murmur suggestive of mitral regurgitation at the cardiac apex. An echocardiogram confirms the diagnosis. Papillary muscle rupture is a rare and life-threatening complication. It causes acute and massive mitral valve regurgitation with no time for the heart to compensate. Dyspnea, pulmonary edema, and decreased cardiac output result from the backup of blood into the left atrium. This condition aggravates an already damaged left ventricle by reducing cardiac output even further. The patient undergoes rapid clinical decline. Left ventricular aneurysm results when the infarcted heart wall is thin and bulges out during contraction. This can develop within a few days, weeks, or months. It is more common with anterior wall MIs. The patient with a ventricular aneurysm may develop heart failure, dysrhythmias, and ventricular rupture, which is usually fatal. Ventricular aneurysms can hide thrombi that can lead to an embolytic stroke. Anticoagulation therapy is recommended for these patients unless it's contraindicated. A new loud systolic murmur heard in patients with acute MI may signal a ventricular septal wall rupture. Depending on the size of the defect and the degree of may occur. The patient must undergo emergency repair, either surgically or percutaneously. The defect can quickly expand and lead to hemodynamic compromise. Left free wall rupture is an emergent clinical situation. Rapid hemodynamic compromise and death ensues if not treated immediately. Patients with anterior MIs, older adults, and women. Fever may persist. The patient may have hypotension and or a narrow pulse pressure if it is accompanied by significant pericardial effusion or cardiac tamponade. Asymptomatic pericardial infusions are common in STEMIs. Diagnosis of pericarditis can be made with the 12-lead EKG. Typical EKG changes include diffuse ST segment elevations in many leads, unlike a STEMI, where the ST segment elevations occur in the leads facing the infarcted wall. This reflects the inflammation of the pericardium. Treatment includes pain relief with high doses of inflammation of the pericardium. Treatment includes pain relief with high doses of aspirin. Non-steroid anti-inflammatory drugs and corticosteroids are avoided the first 4 weeks after an MI because they can interfere with myocardial scar formation. Dressler syndrome is pericarditis and fever that develop 1 to 8 weeks after an MI. Syndrome is pericarditis and fever that develop 1 to 8 weeks after an MI. Although the cause is unclear, it may be an autoimmune reaction to the necrotic heart muscle. The patient has chest pain, fever, malaise, and a pericardial friction rub and arthralgia. A pericardial effusion may be present. Laboratory findings include a high white blood cell count and a sedimentation rate. High-dose aspirin is the treatment of choice. The EKG is the primary tool to diagnose unstable angina or an MI, whether it's a STEMI or a non-STEMI. Again, we need to compare these to previous EKGs whenever possible. The EKG must be read carefully since changes can be absent or subtle at first. Conclusion. ST elevation in the leads facing the infarcted wall is seen first on the 12-lead EKG. ST segment elevation is significant if it's 1 millimeter or more above the isoelectric line in 2 or more contiguous leads. EKG changes in unstable angina or an NSTEMI include ST depression infarct. Both groups of patients may present with angina and have the same EKG changes. The only way to tell if the patient is experiencing an NSTEMI or unstable angina is by drawing cardiac biomarkers. These biomarkers will be high in the NSTEMI patient but normal in the patient with unstable angina. Because MI is a dynamic process that evolves over time, serial EKGs are done to show the evolution of ischemia, injury, infarction, and the resolution of the infarction. Serum cardiac biomarkers are proteins released into the blood from necrotic heart tissue after MI. The onset, peak, and duration of levels of these biomarkers are shown in MI. The onset, peak, and duration of levels of these biomarkers are shown in figure 33.15. Cardiac-specific troponin has 2 subtypes, cardiospecific troponin T and cardiac-specific troponin I. These biomarkers are highly specific indicators of MI and have greater sensitivity and specificity than creatinine kinase MB. Serum levels of troponin increase 4 to 6 hours after the onset of MI, peak at 10 to 24 hours, and return to baseline over 10 to 14 days. Sets of serial cardiac biomarkers are drawn over 24 hours. An example would be every 6 hours times 3. Hours after an MI, peak at about 18 hours, and return to normal within 24 to 36 hours. The creatinine kinase enzymes are fractionated into bands. The CKMB band is specific to heart muscle cells and helps to quantify myocardial damage. CKMB is a less sensitive marker for myocardial injury compared to diagnostic of acute MI. Myoglobin is released into the circulation within 2 hours after an MI and peaks at 3 to 15 hours. Although it is one of the first serum cardiac biomarkers to appear after an MI, it lacks cardiac specificity, which is why it has a limited role in diagnosing MI. The patient with a STEMI MI. The patient with a STEMI must undergo cardiac catheterization within 90 minutes of presentation or receive thrombolytic therapy within 30 minutes in agencies without PCI capability. The goal is to open the totally occluded artery and limit the infarction size. The patient with unstable angina or a non-STEMI usually undergoes cardiac catheterization during hospitalization to diagnose and evaluate the extent of the disease. Guidelines suggest that it is reasonable to do cardiac catheterization on stable but high-risk patients with unstable angina or NSTEMI within 12 to 72 hours after presentation. If appropriate, some patients may be referred for CABG surgery. This chart shows the emergent care of the patient with chest pain. Initially, if unresponsive, assess circulation, airway, and breathing. If responsive, monitor airway, breathing, and circulation. Position patient upright unless contraindicated. Give O2 via nasal cannula or a non-rebreather mask. Obtain baseline vital signs including O2 saturations. Auscultate heart and breath sounds. Obtain a 12-lead EKG. Insert 2 IV catheters. Assess pain using the PQRST mnemonic. Medicate for pain as ordered. Use QRST mnemonic. Medicate for pain as ordered. Usually nitroglycerin and morphine. Start continuous EKG monitoring and identify underlying rhythms. Obtain baseline blood work such as cardiac biomarkers, a CBC, a basic metabolic panel, and coagulation studies. Obtain a portable chest x-ray. Assess coagulant or thrombolytic therapy or PCI as appropriate. Give aspirin unless it's contraindicated. Give a high-dose statin and antidysrhythmic drugs for life-threatening dysrhythmias. Thrombolytic therapy is started if the patient is unable to be quickly transported to a PCA-capable hospital. Dysrhythmias are treated according to age drop-off. Unstable angina patients and non-STEMI patients are treated with heparin. Some patients with unstable angina or NSTEMIs are started on glucoprotein 2B and 3A inhibitors. Glucoprotein 2B and 3A inhibitors may be used during PCI for STEMI patients. The patient with acute coronary syndrome. Most of the care we've talked about has been what we do for the patients in the emergency room. So what do we do once we get them in the ICU? First, we're going to continue to monitor them. We're going to monitor their ABGs, their vital signs, their level of consciousness, their heart and breath sounds, their heart rhythm, and their O2 saturation. We're going to assess and record the rhythm and their O2 saturation. We're going to assess and record the response to their drugs. Do they have decreased chest pain, or are they still having dysrhythmias? We're going to remedicate and titrate those drugs as needed. We're going to provide reassurance and emotional support to both the patient and the caregiver. We're going to explain all our interventions and procedures to the patient and the caregiver. We're going to explain all our interventions and procedures to the patient and the caregiver in very simple terms. We want to anticipate the need for intubation if respiratory distress is evident, and we're going to be prepared to give CPR and defibrillation if cardiac arrest is evident. We also want to anticipate the need for transcutaneous pacing for symptomatic bradycardia or a heart block. When the patient with the STEMI goes for PCI, the goal is to open the blocked artery within 90 minutes of arrival to an agency that has an interventional cardiac catheterization laboratory to limit the infarction size. In this case, the patient undergoes a cardiac catheterization to locate and assess the severity of the blockage, determine the presence of collateral circulation, and evaluate left ventricular function. During the procedure, a bare metal stent or a BMS or a drug-eluting is inserted into the blocked coronary artery. Patients with severe left ventricular dysfunction may require intra-aortic balloon pump therapy and or inotropes such as dopamine. A small percentage of patients may need emergent CABG surgery. The advantages of PCI compared to CABG surgery include is ambulatory shortly after the procedure. 5. The length of the hospital stay is 3 to 4 days after MI compared to 4 to 6 days with CABG surgery, thus reducing hospital cost. 6. The patient can return to work several weeks sooner after PCI compared to 6 to 8 week convalescence after CABG. Thrombolytic or fibrolytic therapy is indicated only for patients with a STEMI. Advantages include availability and rapid administration in agencies that do not have an interventional cardiac catheterization laboratory or when one is too far away to transfer the patient quickly. Patients who are one is too far away to transfer the patient quickly. Patients who are admitted to non-PCI capable hospitals can be moved to a PCI capable hospital if the first medical contact to balloon inflation time can be done within 120 minutes. STEMIs with thrombolytic therapy aims to limit the infarction size by dissolving the thrombus in the coronary artery to reperfuse the heart muscle. The goal is to give the thrombolytic within 30 minutes of the patient's arrival to the ED. The inclusion criteria for thrombolytic therapy is a patient who's had chest pain for 12 hours and a 12-lead EKG that shows considered for thrombolytic therapy. You must have no absolute contraindications. Absolute contraindications include active internal bleeding or bleeding diathesis, which includes menstruation, history of intracranial hemorrhage, intracranial or interspinal surgery within 2 months, known intracranial cancer, primary or metastatic, recent, and that is within 3 months, ischemic stroke, severe uncontrolled hypertension, significant closed head injury or facial trauma within the past 3 months, and suspected aortic dissection. If a patient is treated for any reason with streptokinase, they can't are the absolute contraindications. There are some relative contraindications. They include active peptic ulcer disease, current use of oral anticoagulants, dementia, history of chronic, severe, poorly controlled hypertension, known intracranial pathology not covered in absolute contraindications, major surgery within the last 3 weeks, no compressible vascular procedures, pregnancy, prior ischemic stroke in the last 3 months, recent within 2 to 4 weeks intracranial bleed, significant hypertension on presentation, for example, a systolic blood pressure greater than 180 or a diastolic blood pressure greater than 110, or a traumatic or prolonged cardiopulmonary resuscitation, and prolonged would be greater than 10 minutes. Each hospital has a protocol for giving thrombolytic therapy, but 2 steps: draw blood to obtain baseline lab values, and 2, start 2 to 3 lines for IV therapy. Perform all other invasive procedures before giving the thrombolytic agent to reduce the risk of bleeding. Depending on the type of drug that's selected, the therapy is given as 1 IV bolus or over time, like 30 to 90 minutes. Note the time at which the therapy begins and monitor the patient during and after the thrombolytic. Assess heart rate, vital signs, and pulse oximetry. Assess the heart and lungs often to evaluate the patient's response to the therapy. Regularly assess for neurological changes that might indicate cerebral bleeding. When reperfusion occurs, a blocked coronary artery is opened and blood flow is restored to the heart. Several clinical changes can be seen. The most reliable sign is the return of the ST segment to baseline on the ECG. Other signs include resolution of chest on the ECG. Other signs include resolution of chest pain and early rapid rise in the serum cardiac biomarkers within 3 hours of therapy, peaking within 12 hours. The presence of reperfusion dysrhythmias, accelerated idioventricular rhythm, is a less reliable sign of reperfusion. These dysrhythmias have treatment. Since STEMI patients are taken directly to cardiac catheterization, systemic anticoagulation therapy with either subcutaneous low molecular weight heparin or IV unfractionated heparin is used only for unstable angina and STEMI patients. As I previously mentioned, some of the drugs, whether the patient receives a stent or not, aspirin should never be stopped. Oral beta blockers are given within 24 hours. If there are no contraindications, calcium channel blockers are used if the patient can't tolerate beta blockers. ACE inhibitors are added after MI if there are no contraindications, and nitrates may be used for persistent chest pains. Okay, so let's talk about the drugs used in acute coronary syndrome. IV nitroglycerin is used in the initial treatment of patients with acute coronary syndrome. Sublingual nitro can be used until IV nitroglycerin is prepared. The goal of therapy is to reduce angina pain and improve coronary blood flow. IV nitroglycerin decreases preload and afterload while increasing myocardial oxygen supply. The onset of action is immediate. Titrate nitroglycerin to eliminate chest pain. Because hypotension is a common side effect closely aligned to the patient's blood pressure. Because hypotension is a common side effect closely aligned to the patient's blood pressure, patients who become hypotensive may be volume depleted and may benefit from an IV bolus. Closely assess for volume overload after the bolus. Morphine is the drug of choice for chest pain that is unrelieved by nitro. As a vasodilator, it decreases blood pressure and heart unrelieved by nitro. As a vasodilator, it decreases blood pressure and heart rate. In addition, morphine can help to reduce anxiety and fear. In very rare situations, morphine can cause respiratory depression. Monitor patients for signs of bradyapnea or hypotension. We have previously discussed the use of beta blockers, ACE inhibitors, and ARBs related to the patient with MI. They are also useful in the patient with acute coronary syndrome in that they reduce myocardial oxygen demand and the potential for developing heart failure. This is particularly true in patients with ejection fraction. Lipid-lowering drugs and stool softeners will also be given to patients who are having unstable angina. If patients are hemodynamically unstable, they will be MPO. As this condition resolves, we should advance the diet as tolerated to a low salt, low saturated fat, and low cholesterol diet. A detailed health history, including a history of coronary artery disease, chest pain, angina, MI, valve disease, heart failure, cardiomyopathy, hypertension, diabetes, anemia, lung disease, or hyperlipidemia. When we talk about nutritional assessment, we want to talk about indigestion, heartburn, or nausea and vomiting, urgency or frequency. Are they straining when they have stools? In relation to activity, we want to pay attention to whether they complain of palpitations or dyspnea or dizziness when they are exercising. We also want to assess whether there's been any cognitive change or if they're dealing with any additional stress, depression, anger, or anxiety. They're dealing with any additional stress, depression, anger, or anxiety. Nursing care continues with objective data. We want to be sure and describe events related to the current illness. We want to know if there's a family history of heart disease. As expected, we'd want a thorough cardiovascular history, including tachycardia or bradycardia. Pulsus alternans, which is an alternating weak or strong heartbeat. Pulse deficit, dysrhythmias, especially if they're ventricular. Murmurs, S3, S4, or increased or decreased blood pressure. Lastly, we want to consider our diagnostics, which would include those serum cardiac biomarkers, increased serum lipids, positive exercise or pharmacological stress test, and thallium scans. We'd look for previous EKG changes that we've already talked about, such as ST segment elevation, ST segment or T wave abnormalities, pathological Q waves, such as that. The chest X-ray might show cardiac enlargement, Q waves, such as that. The chest X-ray might show cardiac enlargement, calcifications, or pulmonary congestion. We also might see abnormal wall motion on a stress echocardiogram or a resting echocardiogram. Lastly, the patient may have positive coronary angiography. Please take a moment to look at this list of coronary angiography. Please take a moment to look at this list of nursing diagnoses that might be appropriate for the patient with coronary artery disease or coronary artery syndrome. This slide identifies some of the immediate and long-term goals for the patient with coronary artery disease and coronary artery syndrome, and it is the basis with coronary artery disease and coronary artery syndrome, and it is the basis for the planning of our nursing care. As stated several times, pain is one of the primary signs and symptoms of acute coronary disease and myocardial infarction. Once pain is relieved, some patients interpret the absence of pain as the absence of heart attack or non-sustained VTAC, and depending on the patient's hemodynamic status. Silent ischemia, noted by ST segment changes, can occur without significant symptoms such as chest pain. In addition to routine vital signs, monitor intake and output. Assessment of the patient's oxygen status is important for irritation or dryness, which can cause considerable discomfort. Bed rest may be ordered for the first few days after a large MI. A patient with a non-complicated MI may rest in a chair within 8 to 12 hours after the event. Prolonged bed rest is not recommended. Your role is to identify the source of anxiety. Your role is to identify the source of anxiety and assist the patient in reducing it. If the patient is afraid of being alone, allow a caregiver to sit by quietly and check the patient frequently. If a source of anxiety is fear of the unknown, explore these concerns with the patient. For anxiety caused by lack of information, provide teaching based on the patient. For anxiety caused by lack of information, provide teaching based on the patient's stated need and level of understanding. Answer the patient's questions with clear, simple explanations. Physical activity, an integral part of rehabilitation, is necessary for optimal physiologic functioning and psychological well-being. A regular schedule of physical activity, even after many years of sedentary lifestyle, is beneficial. Cardiac rehabilitation is the restoration of a person to an optimal state of functioning in 6 areas: physiologic, psychologic, mental, spiritual, economic, and vocational. Discuss participation, stable angina, an MI, a PCI, or CABG surgery. These programs are helpful, but not all patients choose to or are able to take part in them due to cost, location, and travel limitations. Home-based cardiac rehabilitation programs can provide an alternative. Maintaining contact with the patient is the key patient or home-based cardiac rehab program because exercise-based cardiac rehab is a Class 1 recommendation from the ACC and the AHA for any patient with heart failure or who had a cardiac event. Despite the proven beneficial effects of cardiac rehabilitation, it's often not recommended. And participation in considering rehabilitation, the patient must recognize that coronary artery disease is a chronic disease. It is not curable. Therefore, basic changes in lifestyle must be made to promote recovery and future health. It's important to include sexual counseling for heart patients and their partners. Many patients change their counseling for heart patients and their partners. Many patients change their sexual behavior because they're concerned about sexual inadequacy, death during intercourse, and impotence. Before providing guidelines on resumption of sexual activity, it's important to know the patient's physiologic status, physiologic effects of sexual activity, and the site in MI. Sexual activity for most middle-aged men and women with their usual partners is considered a moderate energy activity equivalent to climbing 2 flights of steps or walking briskly. It's helpful to consider sex as a physical activity and to discuss or explore feelings in this area when discussing other physical activity. Many people who've had a heart attack wonder whether they'll be able to resume sexual activity. Has this been a concern of yours? This type of non-threatening statement brings up the topic, allows the patient to explore personal feelings, and gives the patient an opportunity to raise questions with you or another healthcare provider. This slide demonstrates some of the expected outcomes of the nursing care that we give the patient with acute coronary syndrome or acute coronary disease. It is by considering these outcomes that we will evaluate the success of our nursing care. Now let's briefly talk about sudden cardiac death. Sudden cardiac death is defined as a sudden unexpected death occurring within an hour of symptom onset. A sudden disruption of heart function from a life-threatening dysrhythmia produces an abrupt loss of cardiac output and cerebral blood flow. Coronary artery disease is the main cause of sudden cardiac death in the United States, especially in adults over 35 years of age. Have a higher incidence of sudden cardiac death as the first manifestation of coronary artery disease than white women. Sudden cardiac death is the initial manifestation of coronary artery disease or structural heart disease in up to 50% of people. However, sudden cardiac death can occur without evidence of coronary artery disease. Ventricular dysrhythmia can occur without evidence of coronary artery disease. Ventricular dysrhythmias like ventricular tachycardia or ventricular fibrillation cause most cases of sudden cardiac death. These dysrhythmias may or may not be associated with an acute MI. Some people have symptoms within 1 hour of a sudden cardiac death event, such as angina, palpitations, dizziness, or lightheadedness. People who experience sudden cardiac death because of coronary artery disease fall into 2 groups. 1, those that have a prior or an old MI, and 2, those who have an acute MI. Those who've had a prior MI and survived sudden cardiac death are at risk for another sudden cardiac death event because of the condition. They are usually referred for an ICD. It's difficult to know who's at high risk for sudden cardiac death. However, left ventricular dysfunction, as demonstrated with an ejection fraction of less than 30%, is the most commonly used tool to help guide decisions about ICD implantation.
People who survive about ICD implantation. People who survive an SCD event need a diagnostic workup to determine whether or not they've had an acute MI. Serial analysis of cardiac biomarkers and EKGs are done to rule out acute coronary syndrome. Because some people with sudden cardiac death have undiagnosed coronary artery disease, cardiac catheterization is done to identify if significant coronary artery disease was the cause of the SCD event. PCI and CABG surgery may be indicated. If no reversible cause is identified and the ejection fraction is low normal, it's useful to know if these people are likely to have a recurrence. Electrophysiologic studies. For patients with syncope, with the suspected cause of ventricular dysrhythmia, an outpatient wearable monitor can be used for up to 48 hours, or a mobile cardiac outpatient telemetry may be worn for 30 days. An implanted cardiac monitor may be implanted in a recurrence of SCD, sudden cardiac death, is the use of an ICD, implantable cardiac defibrillator. It has been shown that an ICD improves survival. Drug therapy with amiodarone may be used with an ICD to decrease episodes of ventricular dysrhythmia if the patient is receiving multiple ICD shocks. While caring for these patients, be a psychological adaptation to this sudden brush with death. Many patients develop a time bomb mentality. They fear the recurrence of the cardiac arrest, and many become anxious, angry, and depressed. Their caregivers are likely to have the same feelings. The grief response varies among patients and caregivers. Be attuned to the specific needs of the patients and caregivers. Be attuned to the specific needs of the patients and caregiver. Teach them accordingly while providing emotional support. Several times we've mentioned cardiac catheterization and PCI, so let's focus on that for a few minutes. For patients with increased angina symptoms, a cardiac catheterization is the gold standard. To identify and localize coronary artery disease. It's also recommended for if the EKG shows ST segment wave changes, not necessarily ST segment elevation, and or cardiac biomarkers are positive. This procedure should be done only if the patient's a candidate for percutaneous or surgical coronary revascularization. If coronary blockage is amenable to treatment, coronary revascularization with PCI or percutaneous coronary intervention may be recommended. PCI may be done at the same time as the cardiac catheterization plaque against the artery wall, resulting in vasodilation and a larger vessel diameter. This procedure is called a balloon angioplasty. Intercoronary stents are usually placed after the balloon angioplasty. A stent is an expendable mesh-like structure designed to keep the vessel open. It provides support to the arterial wall. In this slide, you can see that in the first picture, A, the stent is positioned to the side of the lesion. B, the balloon is inflated, expanding the stent. The balloon is then deflated and removed. And in C, the implanted stent is left in place. There are two types of stents, bare metal stents and drug-eluting stents. Bare metal stents are BMS, drug-eluting stents are DES. A DES is coated with a drug to reduce the risk of overgrowth of the intimal lining within the stent. This is the primary cause of in-stent restenosis. Because stents are thrombogenic, drugs are used to prevent platelet aggregation within the stent and acute stent thrombosis. Drugs commonly used during PCI are unfractionated heparin or low molecular weight heparin. A direct thrombin inhibitor. After PCI, the patient receives dual antiplatelet therapy, referred to as DAP, until the intimal lining grows over the stent and provides a smooth vascular surface. This slide shows right coronary artery thrombotic occlusion in angioplasty. In picture number A, a thrombotic occlusion in the right coronary artery is seen. In B, the right eluting stent. After placement of the drug-eluting stent, or DES, DAP, or dual antiplatelet therapy, is used for a minimum of 12 months. The duration of DAP for patients with a BMS is a minimum of 1 month, and you remember BMS is bare metal stent. With newer generation stents, 3 to 6 is bare metal stent. With newer generation stents, 3 to 6 months of DAP is enough to prevent stent thrombosis. Aspirin must be continued forever. There are several potential complications from cardiac catheterization with PCI, which include abrupt closure,
from a coronary artery dissection or rupture, vascular abrupt closure from a coronary artery dissection or rupture, vascular injury to the artery across the site, acute MI from acute stent thrombus or from plaque dislodging and blocking the vessel distal to the catheterization, stent embolization, failure to cross the blockage with the balloon or the stent, coronary embolization, failure to cross the blockage with the balloon or the stent, coronary spasm, dye allergy, renal compromise, bleeding, infection, stroke, and emergent coronary artery bypass graft surgery. The risk of dysrhythmia during and after the procedure is always present, so patients should be on a cardiac monitor afterwards. Nursing care for the patient post-procedure includes performing a full assessment and comparing it to the baseline. We should also assess care of the catheterization insertion site for hematoma, bleeding, and a bruit. Assess neurovascular status of the hour, then according to agency policy. Check for bleeding at the catheter insertion site every 15 minutes for the first hour, and then again according to agency policy. Monitor EKG for dysrhythmia and other changes. Monitor IV infusions of anti-anginals and antiplatelet medications. Teach the patient and the caregiver about discharge is coronary artery bypass graft or CABG. During cardiopulmonary bypass, blood is diverted from the patient's heart to a machine where it's oxygenated and returned via a pump to the patient. This allows the healthcare provider to operate on a quiet, non-beating, bloodless heart while perfusion to the vital organs is maintained. Cardiopulmonary bypass, though, has its disadvantages in that it's associated with post-operative neurological dysfunction, renal problems, and systemic inflammatory response syndrome. The internal mammary artery is the most common artery used for bypass graft. The proximal part of the mammary artery is the most common artery used for bypass graft. The proximal part is left attached to its origin, which is the subclavian artery. The distal end of the IMA is dissected from the chest wall. Next, it's anastomosed, which means sutured, to the coronary artery distal to the blockage. It usually is used to bypass the left anterior descending or the LAD artery because the LAD supplies blood to the largest part of the heart muscle, the anterior wall. Saphenous veins can be used for bypass graft. Saphenous vein grafts are more prone to develop diffuse intimal platelet and statin therapy after surgery helps maintain vein graft patency. This slide shows a picture of a graft of an internal mammary artery. The proximal end of the left internal mammary artery is left attached to the subclavian artery, and the distal end of the left internal mammary artery is grafted below the blockage. Proximal end of the saphenous vein is grafted to the aorta, and the distal end is grafted into the right coronary artery below the area of blockage. Minimally invasive direct coronary artery bypass graft, or MIDCAB, offers patients with disease of the LAD or right coronary artery an approach to surgical treatment that does not involve a stenotomy and cardiopulmonary bypass. A thoracoscope or robotic assistance may be used to dissect the internal mammary artery from the chest wall, but usually it's done by direct visualization. A mechanical stabilizer immobilizes the operative site. The internal mammary artery is then sutured to the LAD or the right coronary artery. There are two other procedures that might be done, but they actually have limited bypass grafting capability. They are the total endoscopic coronary artery bypass and the transmyocardial laser revascularization. Transmyocardial laser revascularization is an indirect revascularization procedure. It is used for patients with advanced coronary artery disease that are not candidates for a total CABG surgery. The procedure is done using a left thoracotomy approach. It's done as an adjunctive therapy when bypass grafts cannot be placed to reduce angina symptoms. Nursing care for the patient who's had a CABG typically begins in the ICU for at least the first 24 to 36 hours. Ongoing and intensive monitoring of the patient's hemodynamics. The patient will have many invasive lines for monitoring heart status and other vital functions. These include hemodynamic monitoring, an arterial line for continuous blood pressure monitoring, pleural and mediastinal chest tubes for chest drainage, continuous ECG monitoring, The patient may have an endotracheal tube connected to mechanical ventilation. The patient may have an endotracheal tube connected to mechanical ventilation. The patient will have epicardial pacing wires for emergency pacing of the heart, a urinary catheter to monitor urinary output, and frequently a nasogastric tube for gastric decompression. Most patients are extubated within 6 hours gastric decompression. Most patients are extubated within 6 hours and transferred to a step-down unit within 24 to 48 hours for continuing monitoring. Many of the post-operative complications that develop after CABG surgery relate to the use of cardiopulmonary bypass. Major complications from cardiopulmonary bypass are red blood cells and platelets, fluid and electrolyte imbalances, infections, and hypothermia. Focus your care on assessing the patient for bleeding, monitoring hemodynamics, checking fluid status, replacing blood and electrolytes as needed, and restoring temperature. Post-operative dysrhythmias, especially atrial dysrhythmias such as AF surgery, unless contraindicated, to reduce the incidence of atrial fibrillation. Discharge may be delayed in patients who develop AFib in order to begin anticoagulation therapy, especially if using warfarin. Nursing care for the patient with a CABG includes wound care for the patient's surgical sites. Chest incisions are often Chest incisions are often closed with skin adhesive and do not need dressings after 24 hours. Management of the chest wound is similar to that of other chest surgeries. Care of the leg incisions is minimal since endoscopy is used to harvest the vein. Postoperative cognitive dysfunction can manifest days to weeks to months after surgery, but usually improves within a few months after surgery. However, it may become a chronic disorder. In older patients, that means greater than 80 years of age, elective CABG is generally well tolerated. I tell you this to dispel the myth that older people shouldn't have CABG surgery. It's true they may have multiple preoperative comorbidities, so the incidence of postoperative complications such as dysrhythmia, stroke, postoperative cognitive dysfunction, and infection is higher, although the benefits of treatment and mortality are higher than in the younger persons. Postoperative nursing care for the patient with a mid-CAB, OB-CAB, or TCAB procedure is similar to those for CABG patients. One of the major benefits is that the recovery